Our next speaker has also gone to great lengths to come and present, coming all the way from Adelaide. So thank you to Dr. Hannah Wardill, who is an NHMRC Investigator Fellow and head of the Supportive Oncology Research Program at Adelaide University and the South Australian Health and Medical Research Institute. Her research aims to predict, prevent, and better manage the side effects of cancer therapy, with a strong focus on how the microbiome influences individual treatment responses. And impressively, she's leading Australia's first trial of encapsulated FMT for autologous stem cell transplant. Dr. Wardill will present on gut microbiota dynamics and stem cell transplantation. Thank you.
Thank you, everyone. It's a pleasure to be here. I am not a clinician, so I feel a little bit out of my depth in this room, but everyone seems very lovely and warm and beautiful. And also, I loved the shout out to the lab scientists from Wolfie, which we're going with. All right, brilliant. All right, so yes, I'm going to be talking about, I've really adopted the nickname. I hope that's okay. My program of research, as introduced, really does span the whole gamut of supportive cancer care. So I work in hematology, but I also work in solid tumours, right from predicting side effects based on baseline microbiome composition through to more sort of long-term survivorship issues. So maybe a bit of a jack of all trades, master of none, but I just I get excited about all the challenges that we face in supportive oncology. But I have to admit, my pet interest is definitely hematology and transplant complications. So it's a pleasure to be here today. So I think, I mean, really, most of us know now that really the microbiome is absolutely at the center of everything. Whether it absolutely is in a causal relationship is unclear, but it's certainly emerging as a massive contributor to both health and disease. I mean, back in 1681, we had these little creatures that were identified in a fecal sample, but really their influence on host physiology and pathophysiology simply wasn't appreciated whatsoever. Really now with the Human Microbiome Project, which was completed in 2007, they sequenced over 3,000 bacterial genomes. We now have this huge appreciation for just how complex and orchestrated our gut microbiome is. And we know that we are truly more bug than we are human, with the bacterial genome exceeding that of the human genome by about 30%. These values and estimates do seem to change fairly quickly, and there are some extraordinary overinflations on some of these, but this one seems pretty accurate at this point, but could change tomorrow. So there are a number of different diseases that we're now seeing in the literature that are associated with the microbiome, and I think it's really important that we acknowledge that most of these are associative. It's extremely challenging to define causality with respect to the gut microbiome, but we are moving towards causality. And I think some really interesting or some pertinent examples that allowed us to take a step closer to causality was certainly in the sort of neurological space with depression and anxiety, with some of the more famous studies with transferring the blues that really got people thinking and appreciating the role of the microbiome in seemingly distant complications or diseases from the gut. So this was a really pivotal study that demonstrated that if you take fecal samples from someone with anxiety or depression and you transplant those microbes into a germ-free mouse or a mouse without a microbiome, you're able to induce characteristics and behaviors that are consistent with the diagnosis of depression and anxiety. So this transferring the blues was one of the most important studies to really get people thinking that there is a causal role for the microbiome in certain diseases, including those of neurological origins. So we now have this appreciation that the gut microbiome really does have enormous reach and enormous complexity with its relationship with its host. And that is both fascinating, but also extremely overwhelming as a microbiome scientist. One thing that we really do need to appreciate when we're talking about the microbiome is just the huge amount of diversity and variation that exists within the microbiome. And this was a really important study that came out of Sweden, and they looked at the longitudinal composition of the gut microbiome. They sequenced it, I think, at monthly intervals in a cohort of people. And they demonstrated that not only was there very high inter-individual variation in the gut microbiome, which makes sense. Each of us have this unique gut microbiome fingerprint. Some people don't like the word fingerprint, but we're going with it, signature. But what they also identified is that there is significant intra-individual variation, with about 23% of the diversity and variation in the microbiome explained by intra-individual attributes. And so essentially what this means for us is that we've got a very dynamic gut microbiome within each of us. And I think that this video, let's hope it works, shows this really nicely. So this is looking at a principal component plot of the gut microbiome composition. Each dot reflects an individual sample, which is changing over time. So you can see at the top here, these samples are moving all over the place. And so I think from memory, this bottom one is skin microbiome, top left is oral, and top is gut. So you can see an enormous amount of intra-individual variation that's happening in the composition of our microbiome as it shifts and changes in response to our environment. So glad the video worked. So when we think about all the factors that influence our gut microbiome, there are a myriad, and this figure really captures, the absolute superficial surface of this. But this happens right from the moment we're born, with how we're born, whether it be vaginal or C-section, influencing our gut microbiome through vaginal seeding, dietary factors, medications, exercise, diseases, whether you're based rural or in a city, all of these factors will influence your microbiome. And I think diet is a really nice example of just how rapidly we can shift our microbiome. There was a study, this is quite old now, from 2014, but it was a really important study just to show how quickly and functionally diet can influence the microbiome. So this was a study in healthy people. They put them either on an animal-based diet or a plant-based diet. And you can see that the green here is when they went on the diet. And we can see this massive change in the microbiome composition very, very rapidly after the onset of that dietary intervention. And more importantly, functionally, we see that particularly the plant-based diet creates this much more preferable metabolomic profile of the gut microbiome. So really just emphasizing how rapidly and dynamically our microbiome can change in response to these extrinsic factors. So what about when the microbiome undergoes extreme physiological stress, such as stem cell transplantation? Well, it's a bit of a war zone, to be totally honest. The convergence of so many microbiome stresses occurs in the context of stem cell transplantation. And as a result, we really do consider stem cell transplantation to be one of the most profound and sustained microbiome stresses or challenges in sort of the medical field. We do know that chemotherapy itself is minimally toxic to bacteria, but certainly the indirect effects of chemotherapy on mucosal integrity certainly creates a very hostile environment for our gut microbes. They really do rely on those physical niches of the mucosal lining and the nutrients provided. And so when that's destructed, there is a very hostile environment that certainly does not favor our commensal microbes, but in fact favors more virulent pathogenic microbes. Of course, mucosal damage is one component of this, but we know that microbiome stress is exacerbated by antibiotic use, potentially the use of total parenteral nutrition, stress, and also higher interaction with the hospital system. Oh, apologies for these graphs. Not sure what happened there, but stick with me. You can basically see the trends. So this was a study that I was involved in the Netherlands for part of my postdoc, where we were looking at longitudinal microbiome dynamics in a cohort of people undergoing autologous stem cell transplantation. So a little bit less complicated than the allos, obviously. But we can see a really beautiful, although messy, trajectory of loss in terms of the diversity of the gut microbiome, so decreasing over the course of treatment. And we can really see that this maxes out at about the 11 to 30 days post-transplant. This is also associated with a profound loss in systemic short-chain fatty acids. So we heard them briefly mentioned before in the discussion, their ability to have beneficial effects on mucosal integrity, on immune function, even brain function. And we see that these are also heavily depleted. Short-chain fatty acids are really important in acidifying the luminal environment and restricting pathogen growth. So as a result of both the loss of diversity and the loss of acidification of the luminal environment, we do get a very increasing and detectable bloom of pathogens in this patient cohort. And this is very similar to what we see in the allotransplant setting as well. So in terms of the allotransplant setting, excellent. These figures are looking a little bit nicer, which is good now. This was probably one of the most important studies in this space. It came out of the US, where they had over 8,000 samples that they sequenced from over 1,300 allotransplant recipients at 4 centers in the US. And what we can see here, these figures at the top here show the composition of the microbiome in terms of the similarity or dissimilarity between certain samples. And then they're stratified based on the day relative to HSCT or also intestinal diversity. So we can see that there is a shift towards the right-hand side of this figure, indicating that over the course of transplant, the microbiome is shifting in its composition. This aligns with a loss of microbial diversity and also with the expansion of pathogens as well. So again, both autos and allos are showing this domination of pathogens. So this really raises a few important questions, I think. Firstly, what is really driving disruption of the microbiome in HSCT? And more importantly, I think, what are the clinical consequences? So we were really interested in trying to use our clinical trial cohort to evaluate the various factors that were contributing to microbiome disruption in the auto transplant setting. And apologies again. Don't know what's happened here, but that's okay. We looked at a bunch of different factors, including antibiotic administration, dietary factors. We had diet measured every day in this cohort. And we also had citrulline, which is a biomarker of intestinal epithelial mass or enterocyte mass, so essentially intestinal mucositis. And of course, the individual patient was the most dominant feature predicting or explaining the variation in the gut microbiome, because that's the culmination of all factors. But more importantly, citrulline was our predominant factor that predicted or explained the vast majority of microbiome variation in this cohort. So again, reiterating that important mucosal and microbial connectedness. We were able to then demonstrate that when we looked at the longitudinal dynamics of both microbial and mucosal injury, there appeared to be a slight delay in microbial damage. And so we applied some AI and machine learning models to this, and we were able to demonstrate that we could predict future dysbiosis events by tracking the trajectory of citrulline. And we had about a 9-day lag time, which for us was really interesting because it suggests that instead of having to do microbiome screening, we can simply do a citrulline test using blood. And I think, I touched on this a little bit before, this causally implicated or epiphenomenon. This is a really challenging hurdle in microbiome science. We know that microbiome changes consistently associate with many, many factors because we've got a myriad of factors that contribute and influence the composition of the microbiome. And so it is really tricky to decipher. However, I think the HSCT environment does offer actually a really controlled environment where we can look at microbiome changes relative to baseline and look at those clinical relationships, which is really interesting for me. So in terms of really reiterating the mechanistic involvement, I think there was a really important study that was published in 2024 by Anderson and colleagues, and they were really interested in trying to understand, well, what is driving dysbiosis? And actually, they confirmed what we had seen in terms of our clinical data showing that mucosal damage is the predominant feature driving dysbiosis. They were able to demonstrate that essentially dying cells produce factors that really do reprogram E. coli transcription. But more importantly, they then demonstrated that it was E. coli and pathogenic expansion that then dictated the mucosal repair and recovery. So we've kind of got this really horrible and vicious positive feedback cycle that's happening between the microbiome and the mucosa, where the composition of the microbiome is really the driving factor that's dictating how rapidly that mucosal lining can recover, and therefore dictating the duration and depth of injury. So essentially, yes, as I mentioned, the microbiota is really dictating mucosal recovery and therefore the extent and duration of injury. Now, in terms of the clinical consequences, there are a myriad of studies that have now come out showing these really important and quite powerful clinical associations between the microbiome and a range of different outcomes. So this includes bloodstream infection. So there was some really important work coming out of Memorial Sloan Kettering, again, quite some time ago now, but still stands very strong in the literature, really demonstrating that pathogen expansion in the gut microbiome precedes infectious events. There's also a heap of evidence around graft versus host disease, again, in a causality perspective as well, with some really interesting studies using germ-free mice who are essentially nearly protected entirely from GVHD, but I'm not going to touch on that too much because Andrea is going to speak about GVHD next. Transplant-related mortality can be predicted by looking at microbiome dynamics, overall survival, and even relapse. So there really is a very strong evidence base that's coming through the literature at the moment to suggest that these dynamic changes in the gut microbiome after transplant are causally implicated in some of the most challenging outcomes that we see. And so, as I mentioned before, this was the study out of Memorial Sloan Kettering. You can see that when we have domination of Enterococcus, we have a hazards ratio of 9.3 for a then subsequent bacteremia. So really, really, again, reiterating this point of pathogen domination. This is some of the data that came out of, again, Memorial Sloan Kettering, and we can see that if we look at overall survival and treatment-related mortality, when we stratify patients based on their microbiome diversity, so either being high or low, we can see that there are significant differences in outcomes based on microbiome stratification. So again, we're getting these strong associative findings that suggest microbiome dynamics are an important feature in clinical outcomes. But I think something that's really important to acknowledge is that we can't forget about the pre-treatment or the pre-transplant microbiome. So people are coming in with their own unique microbiome, reflecting their environmental factors, but of course, their past history of treatment as well. And we can see that when we stratify based on pre-transplant microbiome composition, we do get not as strong, but we do have some stratification and differences in outcomes as well. Just looking at the time, excellent. So one of the most important and exciting things about the microbiome is this microbiome plasticity, which makes it really challenging because it does change in response to so many things. But it does make it a really excellent therapeutic target because it is quite easy to modify and to target. But the question really becomes, well, what is the ideal intervention? We have diet, we have probiotics, we have fecal transplants, we've got combinations of all of them. Which one is best? And I'm going to flag, and I'm going to say I'm not going to answer that because I don't think we know yet. But what I will say is that we should have a little bit of a word of caution for probiotics, at least sort of first generation conventional or generic probiotics, I should say. And the reason I say this is because probiotics, they are typically made of a limited number of strains, a handful of strains that have been sort of selected, usually out of convenience, to be totally honest. And as a result, if they're delivered in very high amounts, they really can actually counterintuitively decrease diversity in the gut microbiome because that handful of strains dominates that luminal environment. And this was a really important study that came out of a group in Israel that showed in a group of healthy people, they gave them a pretty intense course of antibiotics for a couple of weeks that really depleted their gut microbiome. And they then compared spontaneous recovery, so they just left them. They also included a fecal transplant in the brown. Very, yeah, they could have been a little more creative. So in the brown, we can see that the fecal transplant worked wonders. We had near complete restoration within 24 hours of that fecal transplant and complete restoration by 30 days. We can see spontaneous recovery in the red was sort of partial but totally not complete. But most importantly, we can see in the green with the probiotic that it actually delayed microbial recovery. And this is because these probiotic strains are getting in there, dominating the luminal environment and actually out-competing the microbiome of the host that should be repopulating. So I think this is an important piece of evidence just to throw in here because I think we have this misconception that probiotics are kind of generally safe and fine and won't do any harm. The other word of caution is that there have been some observations. This is not a clinical trial, it's just an observation. But probiotics have been associated with poorer responses in people undergoing or treated with immunotherapy. And again, this comes down to the fact that these probiotics are decreasing microbiome diversity, and we know that higher diversity is typically predicting better outcomes. I think it's also important to acknowledge here that we all have these concerns around infection risk with probiotics in immunocompromised patients, and that is absolutely valid. But I do think that these probiotics that are dominating this luminal environment, if we think back to the work earlier with pathogen domination, this is creating a more pro-infectious environment because we're losing diversity, and it's the diversity in the microbiome that is ultimately the protective feature of the microbiome. So FMT, the ultimate probiotic. Unlike probiotics, FMT really does recapitulate and capture that enormous ecological diversity of the gut microbiome because it's inherently unrefined. There's not much that happens. A lovely donor comes in, they go to the toilet, it's taken, it's mushed up, and it's basically re-administered. There's very little that happens in a fecal transplant. Sorry, maybe we should have gone not directly after morning tea. I talk about poo all day, so I really have no qualms about it. So yeah, the unrefined nature of FMT is actually part of its strength, but also part of its complexity. It's typically administered via colonoscopy, enema, nasogastric tube, and now with capsules, which is excellent, with equal efficacy reported across a number of different indications. And of course, we know that it is used and approved for recurrent or refractory CDI, which is excellent. And this really came out from a really, probably the game-changing trial where they had to actually stop it early for such profound efficacy. So they had 93.8% versus 30.8% efficacy compared to standard of care antibiotics. So again, really reiterating that FMT in the context of Clostridium difficile infection is an excellent, excellent intervention. Now, there have been a number of studies of varying qualities, sizes, etc., that have investigated fecal transplants in the context of stem cell transplantation. So we've had it for CDI, so for Clostridium difficile infection, and also for multi-resistant bacteria. So this was a systematic review and meta-analysis that was performed a couple of years ago by Mallard and his team. And they identified that there was a 78% remission rate for Clostridium difficile infection, excluding case studies, and eradication of MRB of about 73%. So again, really encouraging that we can see transfer of the efficacy in a conventional Clostridium difficile setting into the transplant setting. Again, there have been a couple of other studies looking at FMT for graft-versus-host disease. Again, Andrea will touch on this a little bit more in the next presentation. But it looks like there is certainly some promising evidence coming out, but I think some of these studies have some significant methodological challenges that really probably reflected that these were being tested in a very cautious manner in these early days. So I guess the question really is FMT ready for prime time? And I think the answer is not yet. And this really reflects that there are several challenges that lie in the path for FMT at the moment. So I think one of the biggest challenges is certainly delivering standardized FMT at scale. So FMT currently relies on donor stool samples, so lovely people in the community that are happy to come in and poo on demand, which even that in itself is very impressive, I think. So at Biome Bank in Adelaide, which is a large fecal transplant provider, I'm sure it provides most of the fecal transplants that are used maybe here. They have very strict eligibility criteria, and they have a solid production solid's a bad word, production pipeline, but it's certainly challenging. It's not something that they can continue to do at scale. But I did see on LinkedIn this morning that they managed to culture up with no donors 100 litres of cultured microbes for FMT. So they're definitely moving in the direction of next generation FMT that doesn't have to rely on donors. The other thing that I think is in our way of FMT being ready for prime time is certainly optimizing FMT composition to meet the unique contextual clinical applications. One microbiome is not the be-all and end-all for every condition associated with the microbiome. So there's a lot of work that we need to do to understand what microbial attributes are most beneficial and how do they differ in different clinical circumstances. Administration route and timing is something that's pretty challenging, particularly in the transplant setting, in the stem cell transplant setting. So, in a chronic disease like inflammatory bowel disease or in an acute infectious event like CDI, of course, it makes sense to give a big once-off bolus. However, in the context of stem cell transplantation, where there are many ongoing co-occurring microbial stresses, what is the best time to come in, and how can we do that in a way that is not too burdensome on the patient? I do think that capsules are a really important step forward here because, of course, now we can provide low-dose, long-duration microbial support, and that's what we're trying to do in my trial back in Adelaide. We're doing a peri-HSCT-FMT approach where we give one course of capsules before conditioning chemotherapy and we come in with a second course of capsules once immune recovery is sort of on its way up at ANC 0.8. But of course, early intervention with FMT has been met with a little bit of caution just because of these perceived infection risks. Of course, as I mentioned, that pre-therapy microbiome composition is something that we're going to need to address, but hopefully with strategies like this peri-HSCT FMT, we can begin to think about that. And of course, variable colonization, it is a big challenge. Mucosal hostility creates this environment where donated microbes, no matter how many you give, may not have the ability to durably colonize the host. So, as I mentioned, encapsulated products certainly are assisting, in addition to them just being naturally more tolerable and being able to be delivered over a long period of time. They also can be loaded with other excipients, whether it be prebiotics or mucosally targeted agents to really help colonization. And in terms of the timing side of things, I think it's also really important to acknowledge the study that was published in JCO in 2023 by Rashidi. They looked at FMT for infection control in allotransplant recipients, and whilst they didn't show any statistical improvement in infection, they had no safety-related infectious events. And in this context, FMT was delivered very early, so ANC 0.5 and above for 3 consecutive days. So this is really starting to challenge that assumption that delivering microbes in an immunocompromised host is just a no-go. So I think that this is really starting to push us in the right direction. And finally, next generation FMT products, I think, are really gaining a lot of traction. As I mentioned, BioBank has this 100-liter bioreactor, which is basically a huge colon that ferments microbes. So these innovations are really allowing people to eliminate the reliance on donor stool and instead culture specific consortia of microbes for specific conditions. So I think watching that space is going to be really important for how this field moves forward. The last thing I really wanted to touch on is that not all donors are the same. So we've had a little bit of discussion in the literature about this concept of super donors or super pooers, where essentially we've had these observations in clinical trials where people that have received FMT from the same donor seem to have optimal outcomes, suggesting that there's something unique about that donor or their stool that is conferring an optimal response. But people have looked into this a little bit more intensely, and certainly it's not only explained by the healthiness of that microbiome, high diversity and a super sporty, healthy, plant-eating superhuman. Uh, it really is starting to look like it reflects the ecological compatibility between the donor and the host, very akin to an allotransplant and their recipient. So it's not just matching healthy with healthy, it's actually being much more nuanced in how we match our donor and our recipient. And so we've tried to kind of challenge that or I guess exploit that in the auto setting. We tried to do an autologous fecal transplant in the auto setting, which in theory as a scientist was fabulous. In reality, it was extremely difficult to get people to donate stool right after diagnosis for a potential transplant down the track. It was just, we required huge amounts of infrastructure. So that was that study was ended quite quickly. But in theory, that approach would be very viable from a scientific standpoint. But what does this mean for allos? Should we be sourcing FMT from our stem cell donors? This is a question that we're really interested in, and we're trying to dig into this using a mouse model of allogeneic stem cell transplantation, and we're investigating this concept of donor-matched FMT. So watch this space. Okay, so I think I've stuck to time as well, which is great. So the take-home messages really from today's presentation is that the gut microbiome, as in many, many different clinical environments and stresses, undergoes profound and sustained disruption in the transplant setting, with changes detected more than 100, 200 days after transplant. We know that mucosal injury, so intestinal mucositis, is predominantly the driving force of dysbiosis, but then dysbiosis then exacerbates mucosal injury. So we've got this really complex cycle that we need to unpick. We know that unique microbiome features both before and after transplant predict a range of different outcomes, really clinically significant outcomes. And FMT is really starting to be used in a number of different ways to try and control and optimize clinical outcomes in transplant recipients. And we can administer it safely, including in periods of immunosuppression, but clearly people are still treading quite carefully in that space. So I think now the challenge really lies in how we can optimize FMT production and delivery to really maximize efficacy and our ability to deliver it at scale. So I'd like to wrap up there and thank you all so much for your time, and thanks for letting the little scientist come and speak to you all today. Thank you.